All right. Good, I guess, afternoon, everyone. My name is Tandy A. And full disclosure, because we're talking about hormonal therapy, I'm a pediatric endocrinologist or a kids hormone doctor. So I love hormones, and we're going to talk a little bit about all the things that you might have heard to help give you a sense of what is it that we do over in a gender clinic with hormones. And I would say that hormones in our clinic probably play about 5 to 10%, I think, of all the services and support that we do. And the rest are really a shout out to all the people who are behavioral and mental health providers on the call today, because I think you have a lot of the work that you do, then do a lot of the heavy lifting, and hormones are just a small part in affirming our youth. So, having I'll get started with that. Let me see if it'll advance. I hope that today I can familiarize yourselves with all the different hormone options that are going to be available for our pediatric and adolescent, transgender and gender diverse youth. And then to understand, like, how do we decide who gets what and at what time it's appropriate, particularly in the gender clinics for youth. And then to be really aware of the role that, as a behavioral and mental health provider, how you're so important, particularly in starting treatment, and especially as we continue to follow through. I'm not sure how the group likes to ask questions. I don't mind if people want to ask questions as I'm going along, or if you want to wait to the end. If there is a chat that's going on, it's going to be hard for me to kind of keep that. So if someone wants to, Dr. Withy says, hey,
Yeah,
there's
I'll
some
let you
questions.
know if there's a
Yeah.
chat. No
But
worries.
do you prefer we just kind of go? I don't mind getting questions as we go, is basically.
Either way.
All right. So, as an introduction, puberty becomes really important in all of our treatment, and we always talk a lot about puberty. So, knowing when pubertal development happens for individuals is really important. So, someone who's designated female, puberty can start anywhere from 8.5 to 14 years of age. Now, depending on your culture and your uh, kind of ethnic makeup and family history, there are kids who actually are going to start a lot earlier than even 8.5. For someone who's designated male, they tend to start about 2 years later. And that's just kind of a biological programming. So they can be at about 10.5 when they start. So the range of what we will call peer congruent, or to be like their peers, is quite a big range. And that's really helpful, and we take advantage of that. And puberty, I always like to remind people, most people think of like physical development, right? The secondary characteristics of puberty, but also to remember that puberty is really a component of three parts. Not only you're going to get the physical changes, but the brain development, kind of executive function, the what ifs, not just black and white. Can you kind of go through branching logic, if this, if that? And also the psychosocial development, thinking about relationships, crushes. They call it crush because it hurts, right? And just when you're starting to meet others and who you might be attracted to. And so all three things develop, but unfortunately, they may not all develop in sync. So if you have an 8.5-year-old designated female, they may start with some chest development, but they're still thinking about playing on the playground with anybody who's really maybe perhaps good with jumping rope, or whether it's foursquare. But they're not thinking about it in a romantic way, but they're just thinking of who's the best foursquare person on the playground that I want to beat. And they don't know in terms of executive function. It's more, if I win, I go to the next round. So this is where you can have the different trajectories in development. And that is important for us to know. So, in terms of someone who's coming to our clinic, a transgender youth may identify at any age. And, people think that they're going to be coming to seek hormonal care. And I think a lot of the lay press like to really, especially non-affirming states, or those who aren't as affirming, say, oh, these doctors, they are trying to start hormonal therapies in the 3-year-olds in these gender clinics that come. But that's not what we really do, because hormonal interventions where we're actually doing something doesn't really begin until puberty has started to show. It could be at the beginnings of puberty. So it is important that we do know about timing of puberty and how it runs in a family. And there are three typical presentations that I'm going to just categorize this. Either someone that is before or at the very early stages of puberty, which we call Tanner 1 or 2. 1 is before puberty and 2 is the early stages. Early to mid stage of puberty will go up to Tanner 3. And then coming after puberty is after Tanner 5, because there's only 5 stages of puberty. So if you have someone come before at an early stage of puberty, what I want to make sure is that people even understand what we're looking for. So estrogen is what actually starts those with designated female and having ovaries. They're the ones that make the estrogen from the ovaries. So the first signs are usually breast budding. And because it's a breast bud, I think families don't miss it. Classmates, friends, relatives will notice it. For those who are designated male, where the testes make the testosterone, and that's when puberty starts with testicular enlargement, that often can get missed because, by this age, even if you're talking about a younger age, 10-year-old, most of the kids are showering on their own. Maybe you see them as they're getting out of the pool and grabbing a towel or whatnot, but a lot of times the parents may miss the testicular enlargement until that early stage has kind of progressed. And that initial testicular enlargement is harder to tell, I think, and also it's the longest phase of the 5 stages of puberty, so they're not all equally divided in time, so that someone may spend more time in that Tanner 2 or early stage. But one thing to notice is that what we really don't call puberty starting, in which we're going to talk about medical intervention, has to do with what everybody gets. So yes, you're getting development, and you might get hair down below or hair under your armpits, as I talk to kids, or more formally, axillary and pubic hair. There might be pimples that are coming. So it could be on the face, it could be on the back, even on the chest. I talk about oily hair and oily skin, and I tell kids that's probably when you really have to use soap or shampoo, not just get it wet and come back out. Body odor, I think this, often doesn't get missed. I love the middle school teachers who say first day of school, doesn't matter who you are, everyone gets to stick a deodorant, even if you have no body odor, go ahead and wear it. And then for the person who has to wear it and doesn't feel like wearing it, go ahead and wear it, so that everyone feels like they're on the same page. Now, these changes are not coming from the ovaries or the testes. They come from these little glands that are on top of the kidney called the adrenal glands. And that's why everybody gets these. And that alone, because everybody has the adrenal glands, the features that you get from it is called adrenarche, is the fancy word, or they're starting the adrenal process, but it's not really puberty. So if you only have these changes without breast buds, or only these changes without any testicular changes, then we don't necessarily need to start thinking about puberty that started as needing to intervene. And when we do intervene, the big one that people are always talking about are pubertal blockers. And they're called pubertal blockers because they pause puberty. I think they're more of a puberty pauser than a blocker. But what it means is that it's a medication that we're giving, and we're mimicking the message from the brain to the ovaries and testes to go into puberty. So what happens is when it's time for our bodies to go into puberty, the brain sends the message to the ovaries or the testes and say, hey, it's time to start puberty. And the way that message is sent is very specific. It has to go up and down in a pulsatile fashion. There's a lot of things that in endocrine is pulsatile, and so we get really excited about those things and we nerd out on that. So the way this message is sent, if it's going to be given in a synthetic form, I can have this message be sent and given so that it's always the same. It's a high level and it's not going up and down. And if that's not happening, ironically, the body turns off the internal production. And so the brain tells the ovary and the testes, because it's not up and down, don't work. So then what I've done with the pubertal pauser is I've turned off the internal production of either estrogen or testosterone to be made by the ovaries or the testes. I'll just take a moment here just to make sure that everybody's on the same page so far. Any questions?
Any questions, anybody?
I just see one thing here in the chat. Oh, okay. All right. So these are the forms of the pubertal blockers. There are two options. We have the injectable forms, and the injectable forms can come in either every month, every 3 months, every 4 months, and even 6 months formulation. Or you could get an implant. It's this tiny little straw that goes in the arm, takes a single stitch, and FDA approves it to be used for 12 months. But we know that it will work anywhere from 22 to 27 months. So we keep it in place for 2 years because it's already 50% off. And our site at Stanford Children's was one of the original sites when the medication was going to be coming to market. And we have a lot of data in using it for a while. So we know that it kept working. So why change it if it's still working? And I say it's the 50% discount. And we have a lot of experience with the medication, particularly used for kids who go into puberty too early, as known as precocious puberty. And that's why I think hormone doctors are the ones who typically use these. And I would say the youngest I've ever used it in is a 2.5-year-old who came to my clinic who had puberty. Obviously, 2.5 is not pure congruent, way too early. So then we've used a pubertal blocker. And for those kids who are precocious puberty, they'll probably use it for a much longer amount of time than someone who is coming for gender care, because they don't come in until the signs of puberty are just starting. So they tend to be a little bit older. It's also used in the adult realm. So after breast and prostate cancer, some people are, treated and they need to have their estrogen or their testosterone levels be suppressed so that the cancers don't recur. So in the adult world, the injections are often used in both those with breast and prostate cancers. They have a same medication, but the box that the medication comes in doesn't have a picture of a little kid on it, and that changes the price by a lot. So sometimes what we do is we order the adult medication form and ignore the fact that there's not a little picture of a child on it and use it for a much cheaper price. And this is being recorded, so don't tell that to an insurance. So the considerations in the use of blockers is bone health. One of the big things to remember is that your sex hormones, doesn't matter which one it is, they are so important for developing your bones and your bone health. And pausing the production of any sex hormones may actually lower or decrease the bone mineral density, or the bone density that you probably are familiar from DEXA scans while on treatment. So we know after a hormone blocker is given, maybe 3 months out, you'll start noticing some decrease, and maybe 3 to 6 months, it might be lower. But it's lower compared to their peers who are of the same age if they are going to be in puberty and they're getting the sex hormones. So we do have to be careful of what we mean by that bone mineral density will be lower. You also have to realize that the longer you're on a pubertal blocker and you're missing the time in which you should be getting sex hormones, that you're not building your skeletal strength to be as strong as it could be. So we need to do something about it. So what do? We assume that everybody is going to have this drop in bone mineral density, and there's a debate if everybody should have DEXA scans and be followed. We just don't always get it in everyone. We assume everyone's going to be lower. And instead, we recommend really maximizing that calcium and the vitamin D intake and doing weight-bearing exercises, which can be so hard for our youth because they don't want to be out and about. They already have a lot of body fears and images that are negative. So they might not want to go out and, do things. But it's anything that they want to do except swimming, because in swimming, you're floating and you're not bearing weight. So we encourage even walking the dog, using the stairs, can you bike to school? So whatever you can find, vacuuming is like the best chore to help with this. The advantage of really why do we use this is because by putting pubertal physical development on hold, it gives someone more time to think about their gender identity and exploration. It also gives the time for the cognitive frontal lobe executive function to develop better, and for psychosocial development of kind of thinking of romantic attractions and how they might see themselves with others in relationships. So that if the physical development is happening so far ahead of the other two, you can have time for everything to catch up and help the person be coached on how they see themselves in the world. Typically, other things that happen after this exploration is that really during this time, you're going to be talking to your parents, you're going to be talking to the child, they're going to be talking to a mental health provider and doing some of that exploration and thinking about, readiness for the next step of what they might want to do with their hormonal care and what type of puberty. So they may start with what we call gender affirming hormones around age 14. Some kids are a little bit earlier, maybe 13 and a half or so. And it's testosterone or estrogen. And we like to think about it as, is it going to be a puberty that you're going to have that's programmed from your body? Or are you wanting a puberty in which a hormone doctor might be inducing, or another doctor might be inducing and providing? Both usually start off slow and then they get titrated so that you could get the pubertal development over about 2 years. The timing might be a little bit different depending on when someone had their puberty be put on hold and how old the child is. So around 2 years is an estimate. So we're going to move to second scenario, which is, and I don't know if people want to ask a few questions about the first scenario.
There is a
I
question.
see.
Yeah, there's one. Can the blockers cause osteoporosis or any severe side effects?
Yeah, so thank you, Halen, for that. And there can be severe osteoporosis if, and this is part if, we're not doing the things that we've asked the child to do no matter what. Because we assume, like I said, everyone's bone density is going to get weaker. And having a weaker bone density, by definition, is more than 2 standard deviations than your norm, is what osteoporosis is. And so we do know that that can happen. But we also know that as soon as the child is able to start, by then as a teen, is able to start a sex hormone, whether one that is programmed or one that is going to be induced by the doctors, you're going to rebuild your bone strength. So you're not going to stay in a state of osteoporosis for a long time. Because people think of osteoporosis and like menopause in older people, but the issue there is, once menopause hits, like people are done, and there's not like, oh, we're waiting for a few years and then you're going to get some sex hormones that you're going to be taking. So in kids, it's different because they're going to have that opportunity to catch up. So to avoid having the lowest amount of osteoporosis, that's where we asked, you're doing weight-bearing exercises, you're getting your vitamin D, you're getting your calcium, 3 servings a day or 1,200 milligrams in a day to make sure that you're maximizing bone health and minimizing any chance for osteoporosis. That's the main thing. The other side effect that people worry is fertility. It's almost like the voodoo word that people don't like to talk about. And what I can say is if it's someone who just had to go on a blocker for whatever time and we just stop the blocker, things all return. So if someone's in pubertal development, we stop it, then for 3 to 6 months, everything stops. They're on it for 2 years. And then they say, you know what, I'm completely fine with the puberty I'm programmed to have. I'm just going to stop my blockers. Then everything resumes in about 3 months. And whatever your fertility was in the beginning should go back to what it was at the end. Where fertility becomes a bigger issue is, of course, when you're starting to intervene and you don't want your programmed puberty, then that's a whole other talk that we can have on what can happen down the road.
And we've had a request to talk about the individual different blockers, and I had to look them up because I didn't know what they were. Lupron Depot is probably the one that I'm most familiar with, but
Mhm.
do you have a favorite one?
My favorite one is the one for the patient that the insurance will pay.
Awesome.
We are not, I mean, I have no like conflicts of interest. And I forgot to say that at the beginning. There's no conflict of interest. And my only disclosure is all this medication that we do is all like off label, right? The FDA has not said for gender care in anything. So that would be my biggest disclosure. But anything. So I will tell you when different scenarios where people like it and where we might use it is sometimes, and we'll talk about in kids who are a little bit older, where we might just try an injection first before we do an implant. But in the first scenario, when we're talking about little kids, they're 8.5, 9-year old, they're not going to be on gender affirming hormones till they're about 14. They're going to need to be suppressed for a while. I like the implant, honestly, because they don't have to come and get a shot. I mean, this is a big shot. It's a big old needle, has to be mixed very appropriately, has to be stored and re-administer it. And it goes in I always joke with the kids, where's the biggest muscle in your body? And they all sit there and they think, and they're like, I don't know. And I'm like, you're sitting on it. And then when they find out it's in the butt, I mean, the face just kind of changes, right? So having a blocker placed in the arm and not to think about it for 2 years is great. It also saves time to appointments, right? Missing school or missing work for families to be able to come to get to these appointments. And it also just allows, some normalcy in development and not having to constantly come and thinking I've got something wrong, that I come to a doctor's appointment for injections. So that's why in the younger kids, I do like the blockers. And we have a pretty good team of nurses who work with the insurance. So our one nurse just probably spends at least 50% of her job is fighting the insurance just to get authorization for blockers. And she's really good at it.
Is the implant the Histrulin?
There is Histrulin is the most common one that's used. And there are some other competitors that are coming out to be able to do it, but that is the first one that's out.
Okay, and then the other ones I Googled,
Mhm.
Goserelin
Mhm.
and Triptorelin.
Triptorel, yeah, they're all just different indications or the way they've made and changed so that they all essentially work in the same way. The only other medication that we don't use, and I'll bring up here, and I did make a slide, is what I talked about are GnRH agonists. So they act just like the message from the brain to the testes and the ovaries. And GnRH stands for gonadotropin releasing hormone, meaning the brain is telling our gonads, which are our testes and our ovaries, to make estrogen or to make testosterone. In the adult world, there are medications called GnRH antagonists. So what that is the message from the brain is still going and coming to the testes and ovaries, but it attacks that message almost. It blocks it, like literally. And the reason why we don't use it so much, it's typically used in like endometriosis, is because they have a bigger impact on bone health. So that's why we don't want to use it in kids as much. It's hard to know because, people with endometriosis are also closer to their menopausal years to see, if we used it in kids, is there going to be that much of a bone difference? But because we just want to do less harm and, not have I don't think we ever do a study to compare antagonists and agonists together. Okay.
And then our last question you might be touching on in the future. So tell me if you are. The question is, what are some significant indicators for using a pubertal blocker versus choosing not to? Is that something you're going to touch on?
Yeah, and I'm happy to answer it here too. So the time in which I like to flip the question around is up to what time are you eligible for a pubertal blocker? And I will touch on that. because at one point you're no longer going to be eligible to be able to start with the pubertal blocker. So let me finish with all the scenarios and then I'll reiterate that as well. So in the second scenario, you have a kid who might come in and they're up to the middle of puberty. So they've had puberty for maybe 6, 9 months, maybe even a year. Not everything has completed and they're in that middle stage. And that's when they've come out to say, you know what, I'm thinking about my gender. And you look at them and you say, okay, as a family, you might need more time to still think about this. But we're looking at it and, you know, you're already in development. So we may have to get some blood work to see how much. As physicians, we do have ways that, you know, we try to characterize where you are in Tanner 1, 2, 3. There's formal ways that we look at chest development. We look at, you know, whether it's going to be penile length or testicular size. It's standardized, and it helps us to think about where people are in puberty. But we also will use blood work to help. So if someone came after at puberty, so if you were to stop the program hormone production at puberty, after mid-puberty, what happens is the way to think about it. So if someone already has had a ton of pubertal development, and then we took away that estrogen or we took away that testosterone, the body actually has been used to it for the last year, year and a half, that they actually go through a withdrawal from it, so that the side effects might be greater than the benefits. So a good way to think about it is if you've had estrogen for a while, year, year and a half, you might not have had periods yet, but you've had a lot of chest development. And then we take away the estrogen, you're going to have a change in mood. You're going to have a change in energy. And then just like menopause, taking away that estrogen is going to cause the changes with like hot flashes. So we want to make sure that the side effects of the hot flashes aren't going to be greater than any benefit that would be coming from putting the rest of puberty on hold. And these hot flashes, you know, could just be for a few months, or it can continue. It's just like an older woman who get hot flashes, right? It can be for a while, and it can really be, you know, a couple times a day that lasts for so long and be uncomfortable. In those who make testosterone, we take the testosterone away, same thing, change in mood and change in energy and just kind of feeling really down. So people have described this lack of estrogen or testosterone, if we gave them a blocker, as feeling almost like they had mono. I don't know how many people, I mean, that's something that used to be very more common in high schools, but really feeling tired from that. I'm just looking up here. Someone asked if there was going to be an increased risk of DVT or clotting. I don't think directly from the pubertal blockers. And then remember, what we're asking them to also do is to do weight-bearing exercises. So if you're exercising, that's also going to be decreasing your risk of anything. But you also want to not be smoking and having you know, less cardiovascular risks, meaning eating a healthy diet. It's not all fried. You're getting up to do some exercise and making those kind of choices in eating. But that's for all teens that are going to be there. The next scenario that we have is if someone's already fully pubertally developed and then they present to us, then we don't even offer a pubertal blocker anymore. So that's why I was saying, you know, you have to think about who isn't eligible anymore. And if they've already have had full pubertal development, then they can't get a pubertal blocker because of that withdrawal of the sex hormones when we give it to them, that they would feel so uncomfortable that we could be doing more harm, or so much of a change in their mood that we don't want to be causing more harm. So for those, if they're older than 14 years of age, we'll actually start with either estrogen or testosterone, or talk about that as the next steps and work with you on that. But we can offer some supportive care, and that will be kind of the other hormones and other treatments that are available. So the other hormones. Kids call spironolactone as Spiro. Sounds really cool, or much cooler than what it is. And anyone on here might remember that actually this medication has other indications. And what it's really used for is in older adults as a medication to help with blood pressure. It's actually a diuretic or a medication that can help you pee. And as you pee or void or go to the bathroom, you're going to hold on to your potassium and then you're going to pee out more of your urine, therefore impacting your blood pressure. But there are some side effects at different doses that were noted. And the side effect that's been noted is that it causes less acne and also less body hair growth and development. So not only do we use it, but dermatologists use this all the time. So if you have someone who's getting really bad pimples and before you go on to Retin-A, they might give someone spironolactone just to make sure that those adrenal glands that we talked about that everybody has and makes can have less acne and less body hair development and growth. So it doesn't make the hair go away, but it might be easier to remove that hair, or there might be more time between hair removal. So if you didn't have to shave every other day and now it's every 3 days, it might not seem a lot, but that's 1/3 less of the time you need. So that's kind of how it gets used. It works pretty much of, you take a pill every day. We monitor about a week later to make sure your potassium level didn't get too high. We've never really seen this. And if it did, actually, you're the one state where it might be an issue, because one of the things we say if your potassium gets high is you can't eat as much pineapple. Most of our patients don't have an issue, but the pineapple in Hawaii, I mean, it's really hard to resist. So that might be an issue.
What about
But orange is
bananas,
fine.
though? Bananas
Tomatoes?
aren't so bad. Bananas.
Yes, bananas too. So bananas, oranges, pineapples. I mean, but most of our teams have not said, "Oh my God, I can't have all my fruits and vegetables." That's gonna be right. So it hasn't been an issue. The other thing that you can do as supportive treatment is menstrual regulation. So we might use oral contraceptives or the pill. And there's many, many combinations of the levels of estrogen and the level of progesterone. But a lot of our patients do not want more estrogen into them because they're saying, you know what, I'm identifying as male. I don't want my estrogen. I want to be on testosterone. So why are you going to give me the pill where I have to add more estrogen into it? So I don't want that. So then we might use what's known as the mini pill in the obstetrics and gynecology world, but what it really is just progesterone only. The advantage to that is that there's no estrogen, and the disadvantage to it is that you have to take it almost every day at the same time, within an hour. So some of our teens are really good about it, but some of them can't remember to do something at the same time every day. And when you don't, they'll know it because they'll get some spotting and they'll go, "Oh, I didn't take it on time." And you're like, that's what's going to happen. So some people will go get it as a shot, like the Depo-Provera that I think a lot of you may offer in your offices, or may even get an IUD, just depending on partners and preferences. So they can either, the newer IUDs where it's just progesterone only or without any hormones in it can be placed. And then, talking about hormones, when we do offer treatment, there's testosterone. And there's so many forms, but I will tell you that my favorite form is to start with injection. It's not because we're mean, but really because it is the way to be able to individualize the treatment. I can get it down to the smallest amount that you can pull out of a vial, which is about 10 milligrams, all the way to adult dosing, full dosing replacement that's needed. We teach the patients here how to do it themselves. We don't do it into the muscle, we do it at an angle, and they learn to do it to be either every other week or weekly, and most of them prefer to do it themselves than to have parents or other family members or friends do it before them. Friends is usually a partnered relationship, not like any old friend that they have. Once they get to what I say are about mid-adult level dosing, we give them options, whether they want a patch, a gel, a foam, a deodorant form. It doesn't have any deodorizing, it just goes under the arm. So I call it deodorant, but they still have to actually wear the deodorant at the opposite time. The disadvantage to these is that it's daily. And there's a way in which you have to make sure you're doing it, because as you're giving it or putting it on you, you have to give time for to get absorbed. You have to clean it well. And you also want to make sure that your clothing and towels are washed separately, because all of them is suspended in oil. So when you do laundry with soap and stuff, sometimes if you don't use enough soap or there's enough agitation, it kind of sticks around, and you don't want to get it transferred onto someone else. And it's usually, if there's younger children in the house or whatnot, if you're using the same towels and stuff, they can absorb. The other thing is if you're in intimate relationships, and depending on where you put the testosterone gel and if the other person is exposed, they can also absorb it. And the effects of testosterone are seen sooner compared to estrogen. The first change that you usually see is a change in voice. So, people notice the testosterone effects, so it kind of affirms who they are, and they get very happy in the beginning, because it's like, wow, here I am and I'm noticing changes, I'm on the right path. Things that we monitor during the time is their hematocrit, because if you have too high of a testosterone level, testosterone is impacting your erythropoietin, which is one of the proteins that get made that causes you to have more of the red blood cells. So then you can have a higher hematocrit, which could be at risk for higher clotting. We've never seen it, and the treatment is really just to lower the dose of the testosterone. So we titrate up and we're carefully monitoring. Lipid and liver enzymes, really not something that you're going to be seeing in the pediatric world, but more in the adult world, because of the way in which fat distribution can change with testosterone. It can put you at a higher risk for metabolic conditions like type 2 diabetes, heart disease, because of where the fat is and type of fat the body has. But again, in our adolescents, we're luckier because they're a lot younger and healthier. And then, of course, we monitor their hormone levels and make adjustments. Then there also is estrogen, which usually comes as a pill or a patch. I like to typically just do the pill because it's like the cheaper, easier way. We ask them to just put it under the tongue and let it melt. Usually takes about a minute at most. People have not told me it's bitter and that they tolerate it well. Reason why we put it under the tongue is to bypass the liver so that any inflammation to the liver is avoided as much as possible. A patch is a little bit more expensive. You do still have to change it every so often. You don't have to take it as a pill every day. The patches change once or twice a week. It's more expensive. The people like it if they don't have to remember it. The expense is a disadvantage. And then the other disadvantage is some people actually get a chemical reaction to the adhesive of the patch, and they won't be able to tolerate that. Injections, some people will use injections. We tend to use it in those who cannot, because it's a longer injections. There's people who are trying to use estrogen as injections like the way we do testosterone, but it hasn't been as studied as well. But the injections, you could do a monthly injection so that you don't have to come so often, and people may prefer that just because of distance or other living situations. Again, we monitor the hematocrit here because we want to make sure someone who's going from a testosterone producing and had a higher hematocrit to estrogen and having a little bit lower, we want to make sure they're not getting anemic or the opposite of it. And then liver enzymes, particularly in estrogen, can get elevated. And then the lipid panel, more not because of the side effect of estrogen, but we just feel that what we're noticing is a lot of our youth really can use help with healthy lifestyles. And so we just continue to monitor for that so that they have a healthy lifestyle of exercise and proper eating. And then, of course, we look for their hormone levels as well. Finally, progesterone, another medication that we tend to add. It varies from practice to practice. So some people feel that if they have had estrogen for chest development, they needed progesterone because that is what those with the uterus naturally make in their cycle, and it'll give them better shape chest. Whereas others feel that it's not really necessary and they could get a chest development just as well. So we will start with estrogen, maximize it, and then try in some to see if it's better. part of the reason why we don't give it to anyone is there is an increase in risk for DVTs and clots. So we really look at it case by case. So before we kind of talk about how you support, are there just technical hormone questions? Things you've ever wanted to ask a hormone doctor on?
I don't see any. Anybody?
All right. And I know it's also like the midday, so I might be lulling you to sleep here.
No, we've got a lot of interest. Oh, here we go. How can you tell if the youth is up to mid-puberty? Is it determined by age or time from first period?
So by the time they've had their first period, they're already done with that pubertal development. So when we're talking about pubertal development, it really is the time in which the breast budding starts to the time of their first period. And that's about 2 years, maybe 2.5 years for everybody. So by the time they've had their first period, they're already at the end of Tanner 4 and what we call the very beginnings of Tanner 5. Same thing for those with testes. The very beginning is when the testicle enlargement has occurred. And then at the very end is, usually the big drop in their voice and the last of their growth spurt. And that takes about another 2 years as well. There are formal ways on our exam that we look for characteristically. And because I do lots of Tanner staging, that I know, looking, this is a Tanner 2, this is a Tanner 3, this is a Tanner 4 person.
Thank you so much, Dr. A. And sorry to take up time. I just was wondering if, just to clarify, so if the period has already happened, then you would recommend going into testosterone, like for a, female birth. Yeah, is that right?
We would not
Okay.
do blockers
puberty blocker.
because that would be where you're going to get the menopause symptoms. Because if you give
Yes.
the blockers, you're going to take that estrogen, and the body's been exposed to estrogen for, even with 1 or 2 periods, because you're already cycling, because the body's gotten used to getting message from the brain to the ovary to say, and the uterus to say, shed the lining every month and have a cycle. So if we start giving a blocker, you're going to have the signs of decreased energy, change in mood, and the hot flashes.
Got it.
Now,
Thank you. When we're writing letters and things like that, we shouldn't be like recommending puberty blockers. Like we're not specialists, right? But we might actually be recommending like the testosterone, because the letter that I got was saying puberty blockers, but from what you're saying, actually he should have recommended the testosterone. Is that correct?
yes. So
Okay.
if we do, when I see someone in our clinic and they come and it says a pubertal blocker, I will say, tell the parents why it is not appropriate for them to be on a pubertal blocker, and maybe testosterone is the next step. Then we will send someone back, and I'll talk about what we're looking for at each stage, and say, we can't accept this letter because we want you to have further evaluation and discussions with your therapist.
Thank you. It's so helpful and so informative. I really appreciate it. Thank you.
Sure. I will go back. Someone was saying my favorite forms of the blockers. So if I get someone who hasn't had their period yet, but they're about to, and from an exam, I can say, it's coming in the next 3 to 6 months. Sometimes I will do a trial with the 1 month pubertal blocker, the monthly injections, just to see how are they feeling on it? Like, can they tolerate that change in energy? Can they tolerate that change in mood? Maybe a little hot flash. Like, do they do okay if the family, especially if the child is only like 12 and you're going to have 2 more years before they can get testosterone, and the family is like, we got to do something, we just can't have further. And so we will have a discussion, and on those we'll do a trial and saying, but you have to know, if these side effects are too great, so that your depression is so worse, you can't go to school, you're not being able to get out of bed, and the hot flashes are so disruptive, we're going to stop. And I'm not going to do it as an implant, because the implant is for 2 years. So that's when I might use like a monthly injection, just to see how someone tolerates it. Because if they do fine on that by a month, kind of 1 or 2 months, and then they do fine, then we'll continue it. And then we might switch to a longer formulation.
We've got more questions. Let's see.
Awesome.
Axillary hair for women is the first sign. Or do you,
Actually, it would, so anyone can get that because it's our adrenal glands. So the true puberty development I would want to see is the chest development, the breastbody.
all right, and then there's another comment. I'm more familiar with gender affirming treatments in adults. Curious if for teens on testosterone or estrogen, do you shoot for the same general hormone levels as for an adult patient?
It depends on the age. So if I have someone who had been, affirmed since they were young and they have been on a blocker, and then, hold on one sec, I realized that I advanced my slides by accident. So, and if they've been affirmed and now they're going to be getting the one puberty that I'm going to help with, I'm not going to go for those higher doses because I want to mimic the timing of puberty over 2.5 years. But the main reason is so that they can have the best growth, because puberty is the time in which we have our growth spurt as well. So I'm also monitoring not only pubertal development, how they're doing from their gender, but also from their growth standpoint. It's not an issue in our trans feminine patients as much because they say I come from a really tall family and I don't mind being more petite, but it's really more of an issue when we have our trans masculine patients. And I often hear, in my family, we're not too tall and I really want to maximize my height. So the doses that I aim for may be slightly different in those than in the adult world. I think in the adult world, they go for higher doses. And I do have my older teens saying, but I know, if I have a level of 700, 1,000's got to be better than 700. And we have to talk about symptoms and side effects and what they need that's appropriate.
Thank you.
That's all I see.
All right. So continuing on, I'm going to just talk about letters and roles of people. And I know Halen just talked about how letter writing. So let's get to it. We do require in our clinic for letters for those who are under 18. And we really find it as a great tool to get families actually to be more involved, which may sound almost counterintuitive. First of all, it assesses the understanding of the implications of hormone therapy. It just means that with someone, and I don't like to say, your therapist and your mental health provider, your psychologist, I kind of call them like kind of your coach along the way. They ask the questions, they work with you and say, how do you see yourself? What are your goals? What is it that you're wanting? How is it going to affirm you? And then we talk about not as a diagnosis seeking. I don't need it to say there's gender dysphoria and therefore that's why they need the hormones. What we care more about is, do they know the implications of the hormone therapy? And then are they ready to accept those implications and start it? That is more important. Again, talking about the goals. And for each goal they have for each step of treatment, we actually send them back to get a letter. So if someone is for blockers and they've only talked about blockers, let's just talk about what's, them appropriate at that time. You've got the blockers, you've got more time, and now it's time to think about whether it's estrogen or testosterone you're going to need to affirm and develop your puberty. Let's talk about that then. So it's 2 separate letters that we want, because we want to make sure the whole purpose is that they're doing some continual check-in for a mental health. It doesn't have to be weekly sessions, but it's just that someone's checking in. And the benefits is it's an informed letter. So it's an informed model, right? You had to have a discussion. And it's probably the only way I can get the youth and the parents to come into the same room and talk about these issues, especially about fertility and what it's going to mean together. Because if this wasn't required, I don't think people are going to really want to sit there and talk about it. No one sits at dinner and says, I think it would be great if people did, but, at our dinner tonight, what's your gender identity? What are your pronouns? It's just not something that comes up in daily conversations. And it's also an opportunity because when the parents come, they're so worried that they're going to come to my clinic. I'm going to give them a brown bag and they go home with hormones that day. But when I tell them there's actually these steps and this is what we want to talk about and do an informed consent, it's going to take some time. And for some families, it's in weeks. For some families, it's in a year. And we're here to help you with all the other services. then the parents are like, oh my gosh, like we go to one of these clinics and it's not just them pushing hormones on my kids. And I think it really helps. And it's good for the youth because they're having to really think about their identity and goals. And it's not just like, well, this is what I want. Well, I just want it. And we ask them and we probe. And I think Dr. Brady talked about last week, how do we probe and help the parents and the teens to come together to kind of talk about goals together. And then, if you write a letter, what happens? We review it, both myself to see what the medical goals are, making sure that I can meet some of those medical goals by the hormones, the mental health providers. So Dr. Brady will make sure the letter was done appropriately. If hormone therapy is agreed upon, then we sit down with the family to review the consent, going over the side effects, the benefits, what's long-term, what's short-term, what the timeline is like, and how quickly you see the effects. And then we actually don't let them sign it right there. I tell them to go back, talk about it as a family, whatever, and to give it. I know many sign in the parking lot and bring it right back in, and that's okay. There was some time for contemplation. And sometimes it takes like a week, and sometimes families will get together all together with their mental health provider and talk about it. Then we get some baseline labs before we start treatment. So I always say there's 3 critical steps to summarize. One is a letter discussing a gender evaluation and readiness for the specific hormone therapy. And we do that by partnering with our mental health providers, the consent for hormone therapy, and then the baseline steps and labs. And once we have all 3 steps, then we're able to start treatment. Other things that I continue to partner with is every time we're making a dose adjustment, I like to ask about mood and changes in mood, making sure that other things aren't going on. So if there's a lot of anger, irritability going on, if we're increasing on the testosterone, maybe it's not the perfect timing. We also want therapy to be continuing to talk about further exploration goals and the ups and the downs you may get from being on the hormones. Sometimes there's disappointment that it's not fast enough, disappointment that all the problems don't go away. I mean, it's just hormones, right? It doesn't solve everything. And a lot of our kids have co-diagnoses of anxiety or just depression or disordered eating. And so those things may continue to exist. And I always say in our office, at least, it's a 2-way communication. So we get releases of information, and we want to be in touch with you, and we want you to be in touch with us so that we could work together. So with that, I'm open for any other questions.
Does anybody have a mini case or just a pertinent question? This was an excellent talk. Very.
I'll talk about some of the things that are hard for me, our non-binary patients, right? And then I will go ahead and answer the one question I see in the chat. But I'll bring up, for many cases is when we have non-binary patients, we really like to try to individualize. And that's where it's really important for me to get to understand what they mean by non-binary. What features do they want? Gender fluidity is also important because some of these hormones, I can't switch, between this feature and that feature, right? So what is acceptable? What are your goals? What is it that we want to do? The hardest one we've had was someone who's an excellent singer. And I'm not talking about someone, just sings at school or in the shower kind of person, but this was going to be, was making, cutting records or whichever. And so this is like going to be a form of a profession. But they also wanted to change and transition to be more masculine. But the voice was going to change, right? The voice is going to deepen. And that was really going to impact what roles and what their, role in the band was going to be, or what songs and what notes you can hit. And the person was so convinced, wanted to have a gorgeous goatee. And I was like, look, I can't get you a goatee with a high pitch, voice. It was just not possible. So like kind of breaking down, what was important, why was it? And we got really lucky in that somehow in their family distantly or with someone in working in costumes, they were able to find like some good faux goatee could kind of wear, and then using the voice. But this is where creativity is also important, and listening to the patient and working individually. So that would be a case I would throw out as non-binary.
We do have a question. Oh, okay. Telehealth consultation to Hawaii physicians.
I am so glad that you mentioned it. I see reaching on here as well. It is, I am starting a planning grant for the state of Hawaii to see if such a program would be something that providers where you are would be wanting to partner with us so that we can kind of grow this for all the youth that's in Hawaii, with us the goal of helping you out in the beginning and then, becoming independent in the care. So we would love to be able to partner and start that. And we're just starting to get that information. So if you send your name to Kelly and are, interested in such, she can forward it to us.
Excellent. And then there's another question. At what tenor stage would physical advantages accrue to male transitioning to female be significant enough in your opinion? And do you have any related recommendations you would have for policymakers? For example, competitive high school athletics.
Yeah, that I will tell you. So for the sports, that's a whole other topic we've been hearing, right? And I really want to break it down into two levels of sports, because I just talked to you about, our patients really having a lot of body image, not a lot of negativity. They don't want to exercise. And quite honestly, what we're talking about are the elite athletes. And I think elite athletes, they kind of come up since a young age. Like I knew at a young age, I was not going to be a professional swimmer or a basketball player, volleyball player, runner, whatever the sport. That was just not in me. But some of these kids, early on. So I want to say, policies and people are just really focusing on that elite and trying to make broad policies. But I would like any 8-year-old, regardless of their ability, and their gender identity, if they want to go out and play a sport and be active, oh my goodness, let them be active, right? And especially with their gender identity. So I think we do have to be careful. We are involved in research in which we are looking at, depending on what stage and how much of your hormone exposure you have had, whether with blockers, without blockers, how much of an impact it is making on bone strength, on muscle composition, muscle strength, and muscle mass. And then a new study we're starting is also performance, athletic performance. So there are studies that are being made because this question is going to come up again and again. And some other things I say is, what about co-ed teams? Just let kids just be on a team. And so I'm all in favor of just activity and moving, and not so much of, having to put people into boxes and category, because it's so important to give the kids just a chance to, feel self-confident. I don't know if that helped, and it might be a long answer, but it's just kind of also reframing for policymakers to say, okay, in athletes, and I know the elite teams like the swimming is coming up, and in track and field at Olympian levels, there are committees who are making rules and whatnot. But I think for our non-Olympian athletes who just want to play for fun, like, let's just be more inclusive.
I hope everybody, well, we'll see. That's going to be a hard one for some people to follow. I wanted to let the group know that next week we had a change in schedule because we had a cancellation. So we're going to have Climate Change and Pacific Islanders by Dr. Jacob Lee. So that's next week. And then we have a couple more questions here, but I wanted to let everybody go if they have to go. So the questions are, how long can someone remain on a pubertal blocker, and are there any benefits to starting testosterone at 14 versus 18?
Yes. So I'll answer the second one first. We have shown in multiple studies that those who can be affirmed and supported, the earlier you start from quality of life and decreasing risks for depression, anxiety, and suicidal ideation, is much lower if you're able to start at a younger age than at an older age. So there are some studies definitely out on that. In terms of how long, We typically will not do it for more than 4 years, meaning, past 14, maybe by around 15, if there's no other sex hormone exposure. Because again, thinking about the bones, how strong the bones can be, and if you're having no exposure to any sex hormones, we want to make sure we're not prolonging the weakening of the bones, because you do only build up your bone strength until you're about 25 years old. So we don't want to just say you can be on it, forever, because there are some kids who don't want to make that decision for a long time.
Wonderful. Well, we do have Dr. Gary Okamoto points out that Governor Ige just signed the Gender Affirming Treatment Act, which is explicit about lifting health plan denials based on cosmetic surgery when these procedures are gender affirming. Does California legislature related to gender affirming treatment, does it have something like that?
So not in the specifics of cosmetic surgery, that as far as I know so far, and there are things, in California that are in the works. I do know that you can seek care. And, for those things of how you have to cover. So what I do know for sure that's already in place is that gender affirming treatment, it doesn't say hormones, it doesn't say surgery. If you're a commercial insurance, you must cover it. And I think with having that, we have actually not had problems with our public insurance companies as well, just because we've worked hard in fighting for that and advocating for it. And I know in our state, there have been some thoughts, by age 16, someone being able to seek care just under reproductive care for some of the gender affirming treatments without parental permission is something that's on the table as well.
Excellent. Well, this was a wonderful presentation. I love your presentation style. It's very calm and very informative without, being, I don't know, anyway, it's great.
But you're all very welcoming.
Oh, make sure you look in the chat because there's lots of thank yous there. And hopefully we can have you back maybe next spring and you can tell us any updates or changes or new advice.
Yeah, and I love, like I said, for some of you to be able to participate, and we do hope to have a bigger forum to kind of get into all the other aspects that I think Dr. Brady and I have not been able to address yet. So thank you for welcoming me.
Oh, so wonderful. Well, we already have one email of somebody who's interested. So
awesome. Thank you.
Thank you so much and have a wonderful, evening.
Thank you.
Afternoon.
Bye.
Bye-bye.